Hi, my name's Ian. I'm a physiotherapist. I'm here with Mark, orthopaedic surgeon, and we're going to chat about how the decision to operate is made. I think that it would be fair to say, Mark, that there is an increasing availability of radiology imaging with increasingly high quality, and so we're seeing lots and lots of problems on imaging, and more people are finding these problems. But yet you're the one who is often placed in the position of needing to make that decision. Do these imaging findings, this damage that we can see on the MRI, does that mean we need to operate? So tell us a little bit about how you make that interesting clinical decision.
Yeah, it's a real problem, I think. I agree, Ian, because Dr. Google is probably in some ways helpful on this, in some ways not helpful, because you see the printout of your MRI scan and you've got a list of 10 things that the radiologist has noted as being faulty.
Yes.
So the question then becomes, well, what's normal faulty and what's abnormal faulty? So what is normal aging? What is the cause of my symptoms? What is perhaps just a red herring? A false alarm, as it were. So I think the key thing as a clinician is that you actually want to make a clinical diagnosis at the end of the day, and you want to use the imaging purely to confirm that this is the case or to exclude other pathology. And the imaging quality has become better, no question. So MRI scan 10 years ago to one today, very improved picture quality. It's also become more affordable and more widely available, and it's only going to get more and more so.
Yes.
So increasingly we're going to be have a knowledge explosion in terms of seeing stuff, seeing the cracks in our image, as it were, seeing the cracks in our body, and wanting to know what's worth fixing, what's actually causing symptoms and what's not. And at the end of the day, that actually is still, ironically, has come full circle. It's back to clinical diagnosis.
Can you just tell us briefly what you mean when you say that, when you say clinical diagnosis? So what are you drawing on to make that clinical diagnosis?
So traditionally, when I was training, we were taught, take a history, do an examination and look at the investigations.
Yeah.
And now increasingly we are seeing the investigations first, and then we're having to backtrack, take a history and do an examination. So it's really, I guess, the availability and the sheer huge volume of information with radiology is very threatening to patients, and it's also threatening to us as surgeons because we have to sift through it. But at the end of the day, what I think is becoming more apparent with the knowledge explosion, if you like, in radiological sense, is that some of the pathology is completely normal age-related pathology.
Yes.
So we know now, for instance, that as you age in your shoulder rotator cuff tendons, you would have a 15 to 20% chance of having a full thickness rotator cuff tear that is asymptomatic in your 70s.
Purely through normal age-related change.
Yeah, purely through age-related change. So in other words, I guess the relief is that a lot of these things, in the absence of trauma or the absence of a particular injury, could be considered as normal in the right context, and therefore might not need to be fixed.
Yes.
Which is, I'm not sure that's good news or bad news to some people, but that's the truth.
Yes. I think it potentially puts a surgeon and a physiotherapist almost in opposite positions, because I think, well, certainly from a physiotherapist perspective, my natural inclination and bias is to try to treat things non-surgically whenever possible. But I wonder, I can't speak for you, but I wonder if, as a surgeon, the surgeon's toolkit involves fixing things, whether that's a bias that is difficult to overcome. It's
a native bias. I completely agree with you. So we're interventionists. You're non-interventionists, and an oversupply of surgeons is a dangerous thing, because they will find work. Won't make work, but they'll find work. It's slightly different. But I have been in some places in the West, the ski towns. I remember going skiing a few years ago, town of 10,000 people, there were 14 orthopaedic surgeons, I think. So yeah, you've got to be a little bit careful in those situations. I think if you have an injury with in a town with too many surgeons, it can be a dangerous place to be.
So obviously you are, I know from experience, you are very willing, very happy to recommend non-surgical management for some patients, even for patients where the image, the scan shows very clear signs of damage. But there must be a threshold, a tipping point, some things which would make you say, this rotator cuff tear is going to do better with surgery, whereas I think this one should probably go and have non-surgical management. How do you find that tipping point?
Yeah, I think in the absence of injury, so I think the history is very important. So has there been an injury? Did you fall over? Was it asymptomatic prior to that? Was it symptomatic after that? Or is this something that just came on gradually over time? The evidence with shoulder pathology seems to be pretty clear that you need to, in the absence of injury again, leave things alone for 3 to 6 months easily before intervening, because there is a real chance that things will improve. Similarly with knees, with the natural history of osteoarthritis, by natural history I mean this is what happens just with the passage of time, is that you will have episodes where little bits of cartilage will break off. You'll have an inflammatory response. It'll last 2 to 3 months and the knee will settle down again. Now, if you happen to see me at the start of that 2 to 3 month process,
Everything's flat.
I would say something very different to you at the end of the 2 to 3 month process. So that's what you need to realise. As a surgeon, we're naturally geared towards intervention. And most of the time we're right, but I'd be the first to acknowledge that sometimes if you leave things alone, they may well settle down no matter what the scan says. There are some cases, obviously, where you have to intervene. Young cuff tear, a history of trauma, if the symptoms are unbearable, absolutely. But it's important to realise that some of these things that we are now seeing all the time are completely natural variables of ageing and not necessarily things that have to be fixed. And there are a few variables, obviously age. The older someone is, the more likely they are to have a poor outcome with any surgery. And therefore you become more selective as you get older. I would hope so as a surgeon.
From my reading of the research that's been coming out in recent years about the efficacy of surgery compared to non-surgical outcomes, there seems to have been an increasing number of studies which are suggesting that on average the outcomes might not be very different for some things, as you say, for degenerative rotator cuffs, for example, or for knee arthritis. And so what I know from my own experience is that is a very simplistic way of looking at it, because each patient that you're seeing is an individual, and you have a patient, you can't say that patient is going to get an equal outcome if they go with surgery or with no surgery. Whereas maybe for the whole population, across a large group, that might be true. So yeah, again, I think it comes down to trying to figure out what is the history, what is the examination, what is the imaging, to put that whole clinical picture together and to come up with what's best for that individual person.
Yeah, and some people are prepared to put up with things, and rightly so. I mean, I've had people who've been told they needed a knee replacement 20 years ago, who now are in their 80s and still powering along. I've had some patients who have about to have had an operation, so they've been on the verge of having a hip or knee replacement. Something else has happened, so they've had a heart attack or something like that, and I haven't seen them for years. So people can keep going, especially with elective joint problems. So especially with arthritis, that's the standard osteoarthritis picture that you see. It's certainly possible to keep going for a long period. I've had other people who I've said, look, you have to lose some weight, and they've disappeared, and I haven't recognised them when they've come back.
Yes. Yeah.
I'm sure you've seen the same.
Yes. I find it fascinating as well, that patients, I would suggest that patients don't come to see you because they've got knee arthritis. They would come to see you because they've got knee pain. And you and I both know that there's not a very good correlation between the pain that's reported by the patient and what you're going to see on the image. We see it at both extremes. We see patients with huge amounts of pain where the image looks quite normal, patients who come in with no pain or who've got very damaged joints. So if you do have someone where the pain levels are high, then again, for me, it comes down to, is this a pain management question? Is there something we can do to calm down this irritated or inflamed or sensitized joint? Is there something we can do to calm down this irritated, inflamed or sensitized nervous system that's trying to protect this joint? If we can manage the pain in some way, then perhaps this might turn into a patient who was on the verge of a joint replacement and then 20 years later hasn't had it.
I think either way you've got nothing to lose, especially with arthritis in your major joints, of trying something for a few months to see if it improves you functionally. So the classic for me would be, I think if you put someone on a bike for 3 months pre-knee replacement, I'm not sure a percentage, I won't risk a percentage, but a certain number of people would say, I feel much better, I don't need the operation. And the people who do end up having the operation after those 3 months on a bike will do much better for it.
Absolutely, yes. They've had that capacity building, that strengthening before the operation. They're going to be much more robust and resilient to come out of the operation well.
So that's where a lot of our research is focused now. We're interested in maximising your preoperative function, because I think a lot of people are subtly deconditioned already by the time that's
Yes.
I think you'd agree with that.
Absolutely, absolutely. Let's look at a specific example, Mark. If a patient comes to you and with a partial thickness rotator cuff tear, it's been painful for 3 months, it's really getting to them, what specific advice would you give to that patient? How would you suggest they manage their problem?
Well, I think as we've shown on the webpage, pain's multifactorial, and it's important to work out other factors that might be involved in their pain generation. So, are they sleeping? Sleeping is often the key one that's becoming more apparent. If your sleep's interrupted, you interpret your pain very differently. But from a just a generalisation perspective. This is typically a patient in their 60s or 70s, 3-month history, partial thickness tear on the ultrasound scan. I would be inclined to, depending on the level and the severity of their symptoms and the anatomy apparent on their scans, probably still opt for non-operative treatment with a period of physio, normally closed chain physio exercises, some anti-inflammatories, some modification of activities. It's often just an educational thing of what to avoid, particularly with the painful arc movements. So in this zone here, where you tend to irritate the affected tendons, and also, just the passage of time, I think, is often enough to settle things down. I would often inject subacromial space. That's part of my sort of treatment regime, I suppose, to try and settle things down.
It definitely gives some patients that immediate relief of pain, and some it doesn't. But yeah, I can see why you would want to give that a try.
What about you?
I would definitely be looking at pain management, education, and looking at those other factors, the sleep, and even mental health can have a huge impact. So improving mental health, improving general cardiovascular exercise, get those endorphins pumping a little bit. So finding some good life care strategies can be really useful. But then specifically for the arm, yes, I would be looking for an individually tailored exercise program. As possible, moving towards getting strong. There's a lot of pain relief, I think, that is possible through building physical capacity. I think we talked previously about tendons. There might be another video on the website about that, and how tendons, even tendons that are partly damaged, actually need to be worked to stay as healthy as they can be. Might not be as healthy as it was when it was 20 years old, but it can certainly be maintained and made healthier and happier
Mm-hmm.
putting some appropriate load and tension through it.
Sure.
So finding-
What do you think about? I mean, I have a big problem with physios who don't move patients. So the manual handling, the massages. I mean, I think that might be symptomatically good, but I can't understand why you would stop moving a joint. To me, that's inherently harmful, even if it's uncomfortable. It has to be moved. That's its job.
There's no part of the human body that likes being immobilised or restricted or limited. So the body is amazing in its capacity to adapt and to respond and to rebuild and to toughen and to strengthen, but it needs to be moved for that to happen. So yes, I think there are some hands-on physio techniques which can give pain relief and can sometimes relieve some muscle spasm, and which might create a window of opportunity for the patient to exercise more. So I think there is a place for that, but if it stops at the hands-on physio, I think unfortunately it's a very short-term relief for the patient with no long-term capacity building or longer-term improvement.
Mm-hmm.
Let's try another specific case example. A patient comes to you with a worn-out knee. They've had gradually increasing osteoarthritis and degeneration and pain for the last 10 years, and they come to you at the age of 65. How do you deal with that situation?
So I think again, the first thing to realise is that the surgery is going to make you worse for a while. So all our studies show that knee replacements is a big assault on the body and the musculature around the knee, and it takes you a good 3 months to recover from that. So really there's no quick fix with that situation. It's important to realise that. Again, you want to be in as good condition as you can be before you have a knee replacement. There's nothing to be lost by getting on a static bicycle for 3 months and doing half an hour a day, 2.5 hours a week, pumping away and seeing if you can get rid of those symptoms.
Yep.
The things that have been shown to work beyond doubt with an arthritic knee, so that actual clinical evidence supports the following things: weight loss,
Yes.
activity modification, so staying away from the things that really make it worse, it's common sense, an exercise program. I would favour a closed chain, like we were saying, anti-inflammatories if you can tolerate them, and occasionally a steroid injection. But like I was saying earlier, the natural history of arthritis is you'll have periodic flare-ups. Last 2 to 3 months it'll settle down, and you might find that you reach a comfortable plateau where you can stay for years at a time. So I would generally be very cautious about, most of my people who come and see me for knee replacements have really reached the end of their tether, but it's important to understand that the operation involves significant risk, and you want your patients to be sure psychologically that they're ready for it. We do everything we can to optimise you pre-op, intra-op, post-op, but at the same time it's a big operation. You need to be ready for it.
It strikes me that in some ways your role is one of being a counsellor, a guidance counsellor, because patients will tend to come to you because they're in pain, often distressed, often anxious, got the 10 points on the imaging report.
I'm not a very good counsellor, Ian. I send them to you for counselling. No, I mean, orthopaedic surgeons aren't selected based on their counselling skills, I'm afraid. They generally tend to be slightly autistic.
That's very harsh.
Yeah, but no, I hear what you're saying. I think you get better at it as you get older as a surgeon, selecting patients who will do well is part of the skill, part of the art.
Which I think brings us to a way of wrapping up this little section, trying to talk about that decision-making process. Does this patient need surgery? So what are your take-home messages for people?
By definition, elective surgery is elective surgery. There's no rush to make a decision. You need to carefully research the options available to you. There's lots of stuff out there that you can waste your money on that does absolutely not work, and is targeted at that 2 to 3 month window where you're having symptoms, and you will settle down anyway. And at the end of that 2 to 3 months natural progression, you might say, oh, it was because I injected my knee with this. but actually it would have happened anyway. So don't waste your money on stuff where there's no evidence. The things that we've talked about generally that have evidence are very simple: weight loss, activity modification, exercise, anti-inflammatories, possibly a simple injection.
Thank you.
Thank you.